By the end of this video, the parts of the Paper 2, Pharmaceutics, Therapeutics, and Pharmaceutical dose forms that confuse everyone are going to make complete sense. That's the deal. We're going to strip away the academic fluff and look at this through the eyes of an examiner. We'll tackle bioavailability hurdles, the NTI drug logic that trips up 40% of candidates, and the calculation traps that hide in plain sight. This isn't just a review, it's your tactical briefing. Ready? Let's get to work. Most people fail Paper 2 because they study the facts but ignore the phrasing. Today, we change that. We're looking at the why behind the wrong answers so you can find the right one in seconds. Let's lock in. Okay, let's start with the foundation of how drugs actually get where they need to go. This is where the examiner loves to play with delivery routes. Okay. An examiner will often frame a question by asking why a sublingual tablet is preferred over an oral one for a specific drug like nitroglycerin. They'll throw in distractors about speed of absorption or patient preference, but they're testing if you know about the hepatic portal vein. Think of the liver as a border checkpoint that taxes the drug before it hits the bloodstream. If the tax is too high, the drug dies before it works. What I see students do is pick faster onset every time, but the real answer is usually about preserving the drug's integrity. It's a survival game, not just a race. Got it? When you see a question about VD, the examiner is checking if you understand where the drug hides. They'll give you a scenario with a highly lipophilic drug and ask about its half-life. If the VD is huge, the drug is tucked away in the fat tissues, not the blood. Why does this matter? Because you can't dialyze a drug that isn't in the blood. The trap is thinking a high VD means more drug available, when it actually means more drug is hiding. While we're on this, quick context, remember that neonates have way more body water, which completely flips the VD for water-soluble drugs. Keep that in your back pocket for the pediatric questions. The examiner is going to ask how long it takes to reach steady state after a dose change. They'll give you a complex half-life of 12 hours and ask about a 3-day window. Don't overthink the math. It almost always takes 4 to 5 half-lives, period. The trap is trying to calculate the exact plasma level instead of just counting the intervals. Here's a mini debate. If a patient misses a dose, do you double the next one? Usually, no, because you'll spike above the toxic threshold. The examiner wants to see if you value safety over catching up. Stay steady, stay safe. Now here's the thing about high-risk drugs. The examiner isn't just testing your knowledge, they're testing your clinical judgment. Geiger, nah. For drugs like lithium or warfarin, the examiner will ask about the most appropriate next step when a lab value is slightly off. They'll offer, start the drug as a tempting distractor. Don't fall for it unless the patient is showing actual toxicity signs. Often, the answer is, repeat the test or check patient compliance. The thing nobody tells you is that lab errors happen more often in exam questions than you'd think. Use the mnemonic G-Pac-Man to remember the cytochrome P450 inhibitors that can kick these NTI drugs into the toxic zone. Grapefruit, protease inhibitors, azoles, cimetidine, macrolides, amiodarone, and non-DHP calcium channel blockers. Memorize that list, it's a guaranteed 3 points. Examiners love phenytoin because it breaks the rules. They'll ask what happens to the plasma concentration if you double the dose. If you pick it doubles, you failed the question. Because of zero-order kinetics, a small dose increase can lead to a massive, non-linear jump in blood levels. It's like a traffic jam where the exit is blocked. Once the enzymes are saturated, the drug just piles up. What I see students do is treat it like a standard first-order drug. Actually, let me back up. Always check if the question mentions saturation or capacity-limited metabolism. That's your cue that the math is about to get dangerous. Now here's the thing. The examiner will give you a patient on Digoxin and a diuretic. They'll ask why the patient is suddenly seeing yellow halos. The trap? The Digoxin level might be normal, but if their potassium is low, the Digoxin becomes way more potent at the receptor site. It's a classic therapeutic ambush. You have to look at the electrolytes, not just the drug level. Right, quick reset, always link Digoxin toxicity to hypokalemia. If you see a loop diuretic on the chart, your toxicity alarm should be ringing before you even finish reading the sentence. Okay, let's shift gears to the physical stuff. How we build the medicine matters as much as the medicine itself. Now, here's the thing. Examiners will ask about the difference between an enteric-coated tablet and an extended-release one. They'll use terms like zero-order release or pH-dependent. Enteric coating is a where question. It's about the small intestine. Extended release is a when question. It's about the duration. Don't let them swap the terms on you. A common exam trap is asking if you can crush an XL or SR tablet to put it in a feeding tube. The answer is almost always a hard number. You'd cause dose dumping, which is basically giving the whole 24-hour dose in 5 minutes. That's a one-way ticket to a clinical incident. Here's the exam day version. When the exam asks about flocculation in a suspension, they're testing if you know the difference between a good sediment and a bad one. A flocculated suspension looks messy, but it's easy to shake back up. A deflocculated one looks elegant but forms a cakes at the bottom that's like concrete. The examiner will try to trick you into thinking clear and settled is better. It's not. We want those loose flocks because they prevent caking. It's the counterintuitive nature of pharmaceutics that makes for great exam questions. Remember, messy is often more stable in the long run. Expect a question about why magnesium stearate or lactose is in a formula. These aren't just fillers, they have jobs. Magnesium stearate is a lubricant. It stops the tablet from sticking to the machine. Lactose is a diluent. It gives the tablet enough bulk to actually hold. The examiner will ask what happens if you add too much lubricant. The answer? The tablet won't dissolve because it's too waterproof. It's a delicate balance. What I see students do is ignore the excipients because they focus only on the active drug. Don't do that. The inactive ingredients are often the key to the stabilities or disintegration questions. Stay with me here. When moving into the heavy hitters, the actual treatment choices, this is where the energy builds. The examiner will present a patient with hypertension and a dry, hacking cough. They want to see if you know that ACE inhibitors cause bradykinin buildup, while ARBs don't. The trap is switching the patient to a different class entirely, like a beta blocker, when the logical step is just moving from an ACE to an ARB. Why? Because you want to keep the renal protection while losing the side effect. It's about surgical precision in your prescribing logic. Always check the patient's cough statuses in the vignette. It's the universal code for switch to an ARB. Now, here's the thing. If you see a patient with asthma and high blood pressure, the examiner is baiting you. They'll list propranolol as an option. Don't touch it. Non-selective beta blockers hit the lungs and cause bronchospasm. You need cardioselective ones, think Adamims, Atenol to metoprolol. Here's a quick detour. Remember that at high doses, even selective beta blockers lose their selectivity. So, if the dose is massive, the asthma risk returns. The examiner loves that nuance. It's the difference between a pass and a top score. Right, quick note. The examiner will give you a high INR and ask for the intervention. Is it vitamin K? Is it fresh frozen plasma? Is it just skipping a dose? This is a mini debate of urgency versus safety. If there's no bleeding, you usually just hold the dose. If there's major bleeding, you need the heavy hitters like prothrombin complex concentrate. The trap is giving vitamin K intravenously for a minor elevation. That's overkill and can cause anaphylaxis. Always match the violence of the reversal to the violence of the bleed. That's the rule of thumb for paper 2. Quick reset. Final stretch. This is the highest energy part of the day. We're talking about the final checks that save your score. Let me put it another way. In the calculation section, the examiner is waiting for you to miss a leading 0. 0.5. MJAPs and 5 MJAPT look the same until you're tired and read it as 5 MJAPT. Never, ever write a decimal without a leading 0. In the exam, they might give you 4 answers that are just the same number with the decimal in different places. What I see students do is rush the math because they know the formula. Slow down. Double check the units. Are they asking for micrograms or milligrams? That 1000x difference is the most common reason for failure in paper 2 calculations. Okay. The examiner will ask about a drug that was left out of the fridge for 4 hours. Is it garbage or is it fine? You need to know the big ones: insulin, certain antibiotics, and vaccines. Most of the time, the exam is testing if you know the room temperature stability window. For example, most insulins are good for 28 days at room temp once opened. The trap is picking discard immediately for everything. Think like a practical pharmacist. We don't throw away expensive meds unless the science says they're dead. Check the stability charts in your head before you toss it. Let me put it another way. When asked for the most important counseling point, the examiner will give you 4 correct statements, but only one is the priority. Is it take with food or report a rash immediately? Safety always beats convenience. A rash with lamotrigine could be Stevens-Johnson syndrome. That's a life or death point. Taking it with food is just a tummy aches point. When you're stuck between 2 good answers, ask yourself, which of these prevents the patient from ending up in the ER? That's your winner every single time. We've covered the first pass bypass, the NTI monitoring traps, the physics of suspensions, and the clinical logic of ARBs. You've got the tools to see through the examiner's tricks. Remember, paper 2 isn't just about what you know, it's about how you apply it under pressure. You're ready to hunt for those keywords and avoid those distractors. Let's finish strong. Right now, before you click anything else, go to pharmacycert.com and try 5 free paper 2 Pharmaceutics, Therapeutics, and Pharmaceutical dose forms practice questions. 5. That's the challenge. Then come back and let me know how it went. Like, subscribe, see you in the next one. Go get those 5 right.